Recording start করেছেন না? Okay. All right. Hello, good afternoon. I'm Dr. Jannat or Akter Riva. Today I will be talking about the first class on respiratory system. So we will be having entirely two classes on respiratory system. In the first half, we will discuss about the lung physiology, like the basic respiratory physiology. We will focus on the obstructive airway disease, particularly asthma and chronic obstructive pulmonary disease, diagnosis, management, and also we will try to incorporate the latest British Thoracic Society and the NICE guideline recommendation within our discussion. At the same time, we will also discuss about the pulmonary embolism, management and duration of anticoagulation, and treatment modalities for diagnosing pulmonary embolism. And our last but not least important topic would be different types of pneumonia. And I will discuss about the most important or focus parts of pneumonia that you should prioritize during studying for part 1 or part 2 written examination for MRCP. So before I proceed, I think we are having some new students who will be joining us today. So I think a lot of the students will be joining us for the 4 months module. At the same time, there is also some advanced learner modules present in our discussion. I think for 2 months, Dr. Moinul Ibne Mannan, he's joining us for the 2 months course. So even if you're not able to participate in the later discussions, I can assure you that you will be redirected to the advanced module where through the e-learning platform, you'll be able to learn about the rest of the or the remainder of the discussion or the important topics, okay? So let's see how many participants you're here today. All right, so if you have any queries during my discussion, please let me know. Also, I have prepared some question towards the end of our discussion today. I hope it will be an interactive learning session. Okay, so before further ado, I would just like to focus on few important information, like how many questions. Before today's class, I wrote some instructions. I hope everybody went through that. So Dr. Kobir, can you tell me how many questions from the respiratory system you can expect for part 1 examination? No, it's 14 question, okay? 14 question in total for paper 1 and paper 2, 1 and 2. So I hope everybody knows about the structure of the MRCP part 1 examination. So by this time you already know that this is entirely an MCQ based exam and all the answers will be single best answer. So in the question, there is usually 5 options given and your answer will be one single best answer. Okay, so there will be 200 questions in total consisting of 2 papers, paper 1 and paper 2. Each consisting of 100 questions, okay? So each of this paper will be taking 3 hours. Paper 1 is 3 hours, paper 2 is 3 hours, and there is a gap of 20 to 40 minutes in between, depending on the exam center. And in this paper 1 and paper 2, you can expect 14 questions to come from the respiratory system. So it's not always like it will be following a pattern like 7 question in paper 1 and 7 question in paper 2, not like that. It can come like 3 to 4 questions in paper 1 and the remainder questions will be in paper 2 or vice versa. So there is no hard and fixed rule regarding that and the questions will be scattered. So towards the end when you're preparing for the mock, it will be a bit more clearer to you. Okay, so next up we will discuss about today's topics. So number 1 topic of discussion today will be respiratory physiology. Number 2, we will talk about asthma. Number 3, we will discuss about chronic obstructive airway disease or chronic obstructive pulmonary disease, however you want to mention. Number 4 will be, we will discuss about pulmonary embolism. And number 5, we will discuss about pneumonia. Okay, so these are the 5 topics we will discuss for the first class. As there are some guideline changes for these topics, so I have decided not to bombard you with too many topics in the first part of our lecture or discussion. In the second class, I will discuss about all the things that are quite important for MRCP exam, but those topics are usually not that elaborative. Those are quite precise and very short information. So, so number one is respiratory physiology. So basic respiratory physiology is quite vast. It's a good thing you don't have to go through all of the respiratory physiology for answering questions from the respiratory system for part 1 examination. So what are the important topics for respiratory physiology? First of all, you should focus on spirometry or lung function test and basic interpretation of the lung function test. Number 2, different types of or the components of the lung function test. Especially, I will discuss about which volumes and capacities you should focus on, especially tidal volume, residual volume, and the total lung capacity, vital capacity, and the functional residual capacity. These 5 are particularly important by definition and also by amount or the numeric value. Okay. Number 3, I will discuss about the oxygen hemoglobin dissociation curve. Number 4, I will also discuss in a very summarized portion, respiratory center. It's not that important, but I think it's generally it's a good discussion. And number 5, this is a very important topic from the respiratory physiology, and that is the transfer factor, TLCO or the KCO. All right. So these are just basically recapitulation because we have all gone through these particular topics back in our undergraduate level. So number 1, let's go back. We will be discussing on the spirometry or interpretation of the spirometry. So what exactly is spirometry? It's basically a lung function test. And the most important focuses are given in 2 components. Number 1 is FEV1, which is the forced expiratory volume in the first second, and the other one is the FVC, which is the forced vital capacity, and the FEV1 and FVC ratio. So in terms of obstructive and restrictive lung disease, we already know that FEV1 is basically indicative of small airway. So I'm not sure if you have seen any spirometry curves so far. This is actually this interpretation of the spirometry test is particularly is of great importance for the part 2 written examination, which is why I will not really go through elaborative description of spirometry here. Just remember, this is like a flow volume loop. Okay, this is basically several percentages of the FEV1. This is the versus this is 0, and this is x-axis, and this is the y-axis. Okay, in the y-axis you are getting the forced expiratory volume, aka volume loop. Okay, and on the x-axis this is the flow curve. So particularly if the positive portion, this is the positive deflection indicative of expiration, and the negative deflection is indicative of the inspiration. Okay, so this is, imagine this is a normal flow volume loop. So what happens in case of an obstructive airway disease, the FEV1 is indicative of small airway, expiration through the small airway. So whenever there is some form of obstruction, so this loop will be somewhat depressed like this. This is known as the coving. So if this is the normal, if this is a normal expiratory loop, and if there is some form of depression or coving, that is indicative of obstructive airway disease. Okay, and in case of a restrictive lung disease, both of these loop, like the expiratory loop and the inspiratory loop, will be smaller. So it will be, the shape will be like a normal flow volume loop, however the size will be smaller in case of a restrictive lung disease. Okay, so both the expiratory and the inspiratory loop will be smaller. So for example, if this is a normal loop, okay, so this will be the outlook or the general impression. The inspiratory loop will be actually not impaired in case of obstructive airway disease, but in case of the restrictive airway disease, both the expiratory and the inspiratory loop will be hampered. So this is the obstructive pattern, and if this is the normal shape, Imagine this is the normal shape, and this will be just slightly smaller, okay, in case of the restrictive variety. So just know the general impression. You don't have to go through details of this. So basically, the FEV1 will be significantly reduced in case of obstructive airway disease, and the FVC will be either reduced or normal. So basically, the FEV1 and the FVC ratio will be reduced in case of the obstructive airway disease. In case of the restrictive airway disease, in case of the restrictive lung disease, not airway, it's a pulmonary condition, basically involving the parenchymal involvement, or maybe from outside, like in case of neuromuscular disease, or maybe from bony deformity. This will all be within the restrictive lung disease. So in case of restrictive lung disease, FEV1 is reduced and FVC is significantly reduced, okay? So the ratio is FEV1 or FVC ratio is either normal or increased in case of a restrictive lung disease, okay? So the cutoff value is, in some book, it is said 80%, but for MRCP Part 1 examination, we will remember 70%, okay? So if the cutoff value is less than 70%, this is obstructive airway disease, and in case of the restrictive lung disease, this is either 70% or more than that, okay? So what are the different examples of obstructive airway disease? This is another undergrad level topic. So Dr. Kobe, as you're recently done with MBBS, so can you give me some examples of obstructive airway disease? Mm-hmm. Okay, any other examples you would like to add? These are the major examples, you're right. But there are some other conditions which can also present in an obstructive pattern. Yes, very good. So bronchiolitis obliterans, which is seen in rheumatoid arthritis patient, and bronchiectasis. Bronchiectasis is a very, sometimes it can present in restrictive manner as well, but we will not try to confuse ourselves here. Bronchiectasis, we will remember this is gross distortion of the small airway and repetitive infection causing this kind of distortion, okay? So asthma, COPD, bronchiectasis, and bronchiolitis obliterans, these are the 4 examples of obstructive airway disease, and rest of any other lung condition will belong in the restrictive group, okay? All right, so from the spirometric interpretation, our next topic of discussion from the basic respiratory physiology is different components of the spirometry. So important ones I will focus on. First of all, we will discuss about the total lung capacity. Total lung capacity is the maximum volume of air that you can take in through inspiration and keep it within your lungs, okay? That's the total lung capacity. And the volume is usually higher in case of male, and the volume is usually lower in case of female because of physiological difference. And the total lung capacity is roughly around 6 liter, okay? And in case of female, it's either 4.5 to 4.8 liter. And then comes the vital capacity. So what does a vital capacity mean? It's both the time, it will be maximum, okay? So that will make you a bit easier to remember it. So this is the maximum amount of air that a person can expire after taking maximum inspiration, okay? So the vital capacity is roughly around 5 liter. This is 4,500 ml in case of male and 3,500 ml in case of female. Next up is residual volume. So residual volume is basically after taking a maximal expiration, the amount of remaining air in the lung. That's the residual volume. And residual volume is roughly around, I think 1.2 liter. Let me just check. Remembering these particular things are quite tricky. Even I find it a bit difficult, and I'm very sorry to tell you that this is there is no hard and fast like mathematics to remember it by. So yeah, vital, I think residual volume, I'm right about this one. So residual volume, there is only one max, and that is maximal expiration. So this is the volume of air remaining in the lungs after taking maximal expiration. So this is roughly around 1.2 liter for both male and female, okay? After the residual volume, we will discuss about the tidal volume is, I think, the easiest one to remember, because this is actually during rest, the volume of air that you are breathing in or breathing out. So this is a very easy definition to remember, and this is roughly around 500 ml in case of male or female. Okay, and now this is actually the most important portion, the functional residual capacity. Okay, FRC. Even if you forget about all this definition, like the total lung capacity or the vital capacity or the residual volume or the tidal volume, do not by any means forget the definition of a functional residual capacity. Okay, so what is a functional residual capacity? I want you to focus on residual volume here. Residual volume is the volume of air remaining in the lung after a maximum expiration. So forced residual capacity is something like after taking a normal expiration, the volume of air that is remaining in the lung, okay? So the volume of air that is in the lung after taking a tidal breath, that's the functional residual capacity. So generally, think of yourself. It will be more than the residual volume, right? Of course, because in residual volume, you're taking the maximum expiration, and then the volume that is remaining in the lung, that is the residual volume. But in case of the functional residual capacity, this is the normal breath or expiration that you're taking and the amount of air remaining in your lung. Okay, so this is actually double the amount of residual volume. So this is roughly around 2.4 liter. Okay. So I think these are the 5 most important definitions you should focus on, and the numerical value of each of this lung capacity or volumes. Okay, where's? Okay, next up we will discuss about the oxyhemoglobin dissociation curve. Back in my clinical science class, I don't know how many of you have participated in that. We have had a very elaborative discussion on the oxygen hemoglobin dissociation curve. However, it's not only important from general aspect, but at the same time, it's quite important for the basic respiratory physiology as well. So first of all, what does an oxyhemoglobin dissociation curve mean? This is a temporal relationship between the hemoglobin oxygen binding capacity to the hemoglobin in the face of partial pressure of oxygen. Okay, so the relationship is described by the oxyhemoglobin dissociation curve, and whenever the curve is going to the right, shift to the right, meaning that there is increased oxygen delivery to the tissue level. Okay, increased oxygen delivery to tissue level. So that will so imagine in conditions where your tissue needs more oxygen, those are the conditions this curve will be shifting to the right. So what are those conditions? For example, when the partial pressure of carbon dioxide is increased, when there is acidotic changes in the body, so that means when the hydrogen ion concentration is increased or the pH is reduced, okay? When there is increased temperature or increased 2-3 dpg levels. And here I want to focus you on to one thing, and that is carbon monoxide has a better affinity to binding with the hemoglobin rather than oxygen, okay? So carbon monoxide will cause the oxyhemoglobin dissociation curve shift to the left, which is why in carbon monoxide poisoning, one of the hallmarks is hypoxia, okay? This is an important question from carbon monoxide perspective. At the same time, I think I haven't already mentioned like a effect, Bohr effect and Holden effect. Sometimes for true false statement, these type of effects, they might come up. So Bohr effect basically means when there is increased partial pressure of carbon dioxide, oxygen binds less well to hemoglobin. This is known as Bohr effect. So Bohr effect will cause the oxyhemoglobin dissociation curve shift to the right. Okay. And Holden is another gentleman who thought that, hey, you know what, I'm just going to copy Bohr, but I'm going to make it look like a bit more professional way. So what does Holden effect mean? It means in the face of increased partial pressure of oxygen, carbon dioxide will bind less well to hemoglobin. Okay. So remember the Bohr effect, the opposite is basically Holden effect, okay? And the Bohr effect will cause shift to right. That's how you should remember it. Because sometimes instead of giving you like straightforward options, like, partial pressure, increased partial pressure of carbon dioxide, they might give you which of the following condition or effect is shown to be associated with oxyhemoglobin curve shift to the right. And the answer, the options will be either Bohr effect or the Holden effect. So you have to pick the Bohr effect from the option. Okay. Okay, so next up I will discuss about a very generalized scheme of the respiratory centers. So first of all, the respiratory centers, their location is 3 types, okay? Number 1 is central. So these are located particularly in the brainstem area. Number 2 is peripheral. So their location is in the carotid and the aortic bodies. And number 3 is pulmonary receptors. Pulmonary receptors include 3 types of receptors. One is stretch receptor. So when you try to take a deep breath in, your lung compliance increases and causing the stretching of these kind of receptors. So there will be a limitation to your breathing, and that's when your lungs will decide now it's time for collapse, okay? Because if you just if these stretch receptors are not stimulated, your lung will not be having more space because this is confined with the rib cages, okay? So then at some point they need to stop expanding, all right? So this is the function of the stretch receptor, and this action has been described by Herring-Brewer, which is also known as the Herring-Brewer reflex. Okay, number 2 is irritant receptors. So imagine whenever there is some form of irritant substance you're breathing in or something, you're vigorously coughing or sneezing out, right? So that's thankfully to these irritant receptors, they cause bronchoconstriction or bronchospasm. Thereby, they will be trying to repel that foreign particle out of your system. Okay, number 3 is juxtacapillary receptors. So their main mechanism is whenever there is hypoxia, for example, lack of partial pressure of oxygen, the pulmonary arteries will be causing vasoconstriction. Pulmonary arteries will be constricted. What's the function of this? And that's because of this juxtacapillary receptor stimulation, okay? So what happens if the pulmonary arteries constrict themselves in the face of hypoxia? So it will make sure that in the better aerated portion of the lung, the oxygen delivers and maintains the homeostasis, okay? So basically the lung will be trying to survive or make itself viable. As the hypoxia is taking place in one place, so they will stop working over there by causing vasoconstriction, and they will divert the blood to better aerated spaces for the lung viability, okay? All right, and the central receptors and the peripheral receptor. In the central receptor, there are actually 3 different types of receptor. One is medullary. This is the main brainstem receptor, especially maintaining our respiratory drive. Number 2 is apneustic. Just remember the names of this, okay? Apneustic and pneumotaxic center. And all of these central receptors are very much prone to, or they're stimulated by, rather than increased partial pressure of carbon dioxide, okay? Their biggest drive is stimulation or stimulatory drive is partial pressure of carbon dioxide rather than lacking the partial pressure of oxygen, okay? That's all you need to know. All right, now the final topic from the respiratory physiology is the transfer factor. TLCO or KCO. This particular topic, I would advise you to give it a read from Sudha Medicine if you haven't already. So basically, what does transfer factor mean? It means the rate of carbon monoxide diffusion, rate at which carbon monoxide is diffusing across the alveolar membrane into the blood, okay? So this will actually prompt us into understanding the lung pathology. So there are conditions when the TLCO is increased. And what does KCO mean? KCO is basically TLCO, but adjusted for the lung volume. Adjusted for lung volume. This is also known as the gas transfer coefficient. All right. So the conditions in which the transfer factor is increased are the conditions when there is increased amount of load in the pulmonary vasculature. So for example, in case of asthma, whenever there is pulmonary bleeding, like pulmonary hemorrhage, for example, Wegener's or maybe Goodpasture syndrome, anti-GBM antibody associated, okay. Then in case of high cardiac output, like heart failure, increased cardiac output heart failure can be another cause. And male sex, also exercise, all these things can cause. And I think there is another causes for increased TLCO. Oh yes, when there is polycythemia, okay. So of course, if there is increased amount of blood flow in the pulmonary vasculature, the TLCO will be increased. So these are the conditions in which the transfer factor will be increased, and all the other lung pathology, the TLCO will be reduced, okay. So for part 1 examination, you might also need to consider where the KCO is increased, but the TLCO is normal, okay. So just a sec. Okay, yeah, sorry about that. So KCO is increased when the TLCO is normal. These are the conditions when the lung volume is compromised, okay. So for example, pneumonectomy or lobectomy. Another one would be ankylosing spondylitis, because from the external compression, the lung volume is reduced. And in comparison to that, the carbon monoxide diffusibility is not hampered, okay. So in those conditions, the transfer coefficient will be increased, but the total lung transfer factor will be normal. Just remember conditions when the lung volume is compromised, okay. So far from the respiratory physiology, are you having any questions at all for me? You can let me know regarding this lung function test or the different components of the lung function test, oxyhemoglobin dissociation curve, because sometimes, like true false statement type of questions can come from respiratory physiology. And most of I'm very sorry to tell you, you have to probably cram some of this information, because sometimes in a very short span of time, it's very difficult to use logical thinking, okay. Some information needs to be utilized by the cramming portion, cramming mechanism. So any questions so far? Okay. So if no question, then I will go to our next topic, which is asthma. So asthma is basically one of the most important obstructive airway diseases. And compared to COPD, we have all gone through this, like what are the differences between asthma, COPD, and all these things. So how would you like to, what makes you think that this patient is suffering from asthma? So what are the important diagnostic criteria for asthma? Can anybody tell? Mm-hmm. Okay, you're right about the first diagnostic criteria, because nocturnal symptom or early morning symptom, these are high probability criteria for asthma, okay? So what are the, actually British Thoracic Society has considered, like before considering the diagnosis of asthma, you can take into consideration of high probability, intermediate probability, and low probability. And Trial of treatment is considered to be started first in case of high probable asthma without even going for the spirometry test, okay? Because those kind of patients will benefit from that treatment. So no need to go for it. If you're highly suspecting this is an asthma and it sounds like asthma, you should probably start the treatment. If you're having a diagnostic dilemma, that's when you can go for the spirometry test. So what are the high probability criteria? So one of the symptoms is chest tightness, wheezing, shortness of breath, all these symptoms, or cough, particularly making the patient, like wake up at night, like nocturnal, late at night. Nocturnal symptoms are early in the morning, okay? Number 2 criteria is a positive family history or history of atopic condition, like maybe allergic rhinitis, hay fever, or eczema, a childhood illness of eczema. These will be another diagnostic criteria for high probable asthma. Okay, number 3 is on the clinical examination, if you find audible wheezes, okay? And number 4 is unexplained peripheral eosinophilia. Okay, so nocturnal symptoms, number 2 is atopicity, number 3 is audible wheeze in examination, and number 4 is eosinophilia, okay? So these are, if any of the symptoms are present in one individual, you can consider this is a high probable case of asthma. So a trial of treatment can be started in them. Intermediate group, as you're having the gray zone of clinical diagnostic dilemma, so you can go for the spirometry test. Now, if in the spirometry you're seeing the FEV1 and the FVC ratio is less than 0.7, you can start the treatment for asthma. However, if this is a case of FEV1 and the FVC ratio more than 0.7, then you can consider it to be a low risk asthma and you can do further investigation, okay? Now, what are the investigations and what are the investigation criteria for asthma? Number 1 is FEV1 FVC ratio will be showing obstructive pattern. So that means less than 0.7, okay? With the high probable clinical criteria or intermediate risk factor, but the FV1 FVC ratio is showing less than 0.7, meaning that there is some form of obstructive condition going on. If this is not conclusive, then the second one you can go for is post bronchodilator test. So what we are trying to see is the reversibility. So after giving a patient bronchodilator or generally like prednisolone, inhaled prednisolone, if there is more than 400 ml of improvement from the initial baseline, that is indicative of asthma. But in case of a COPD, there will be no response or limited response or maybe less than 400 ml of improvement. If this is still inconclusive, then another thing you can do is peak expiratory flow rate, and it will show more than 20% diurnal variation, especially in the morning. So the peak expiratory flow rate will drop down, particularly more in the morning, more than 20% changes, okay? That is also indicative of asthma. These 3 particular criteria is very important, okay? So first of all, you need to focus on the FEV1 FVC ratio. If it is showing obstructive feature, you can consider it to be asthma. If this is somewhat inconclusive and you're still suspecting this is a case of asthma, you can go for the post bronchodilator test. If this is showing more than 400 ml of improvement from the initial baseline test, then you can consider it to be positive. If you're having, again, clinical dilemma, then you can go for the peak expiratory flow rate, which will be showing more than 20% diurnal variation, particularly in the morning. Okay. So there are actually different types of variants of asthma, which can come frequently in the part 1 examination. One of the most important one being is the occupational asthma. Before I discuss about occupational asthma, Dr. I forgot your name, sorry. Ovijit, okay. Dr. Ovijit, can you tell me what are, like in general, you don't have to focus on the occupational asthma, but in general, what are the triggers for asthma, any patients with asthma? Mm-hmm. Yes. Mm-hmm. Isocyanate, very good. Yes, moldering agents. Yes, very good. Any type of occupational hazard where there is increased chances of getting exposed to, like heavy metal or toxic fume. Okay. Any other? You have covered most of the triggers actually. Important to note is pets. Okay. If you're having pets, sometimes you can be allergic to pets. Another important one we often forget or maybe ignore about this is exercise can also induce asthma, okay? Exercise and some medications like NSAID or aspirin. Okay, all right. Very good that you have gone through the occupational asthma trigger because isocyanate is the most common culprit for triggering occupational asthma. Number two is flour. Okay, you might be surprised how flour or grain, they can be triggering factors for asthma as well. This is particularly seen in people who are doing their job as a chef, in pastry chef. Okay, so how do you diagnose? And there are some other important exposures as well. One of them is being the smoldering agents, smoldering agent, or just toxic fume in general. So, but do not forget about isocyanate and flour, okay? Number two is how to detect whether this is a case of occupational asthma. So from the history, one of the striking features would be the patient will be having less amount of symptom when the patient comes back home or over the holidays or maybe over the weekends, his symptoms might even go away, okay? And if he takes a longer vacation in a remote location, then he will be saying that, okay, you know what, last time I went to Spain and that time I did not have any symptoms at all. And now I'm having, every time when I go to my workplace, surprisingly, it feels like I'm catching up my breath and I'm having all this difficulty, like cough and all these things. So this is a very classical or typical characteristic of an occupational asthma, okay? So in that case, what we can do is we can tell the patient to keep a peak expiratory flow rate diary. And the readings will be taken 2 times daily in the morning and late at the evening. And we will see how many times the peak expiratory flow rate is dipping. And we will try to observe a pattern, okay? That's how you can diagnose a case of occupational asthma. So most important management for occupational asthma is to consider job modification. Secondly, using personal protective equipment. Number third is refrain yourself from further exposure, okay? So we are not starting the treatment in occupational asthma, all right? So what we are trying to do is we are trying to avoid the trigger and consider job modification and use personal protective equipment. All right. So now we will get back to the asthma management. There are actually so many guidelines internationally and also in our country. The GINA guideline is actually used. However, as we are dealing with a British exam, so I think we have to focus on the British Thoracic Society and NICE guideline as well. First, I will discuss about the general asthma management scheme, and then I will discuss about what is the latest change, okay? So number one is, imagine you have diagnosed a patient with asthma, okay, after doing so many tests and considering the high probable risk factor, low probable risk factor, whatnot. And now you want to give the patient or start this patient with some medication. So your step one is start with a SABA, which is a short-acting bronchodilator. Any name? Dr. Kobir? Any short-acting bronchodilator name of it? Salbutamol. Salbutamol, exactly. So step two is, if the patient is still having symptoms, what you can do is you can combine SABA with a low dose inhaled corticosteroid. So low dose being 200 to 800 mcg. However, it's quite a good approach to start with 400 mcg, okay? Step 3 is if the patient is still showing symptoms or not well controlled. In that case, you can consider to act a LABA. Okay, Dr. Obhijit, give me one example of LABA. Formoterol, salmeterol, exactly. So after starting with the LABA, what we can do is, number one, we can see whether the patient is responding to it. If the patient is responding to this step 3 management, we will continue LABA, okay? If the patient is showing some benefit, but the disease is in general not well controlled, in that case, we will continue LABA, but at the same time, we will increase the dose of inhaled corticosteroid. And if there is no response to long-acting bronchodilator, then we will go to step 4 management. Here in the step 4, you can, if no response to LABA, then you can also stop the LABA here, okay? And increase the dose of maximal high dose of inhaled corticosteroid in step 4, like maybe even 2000 mcg, you can go for that, okay, in step 4 management. And if still not showing sign symptom control, then you can consider adding another medication like leukotriene receptor antagonists such as montelukast or modified release theophylline or even oral SABAs, like in the tablet form. And step 5 is, if the patient is still having symptoms, you can consider oral prednisolone in the lowest dose possible, because oral prednisolone or systemic prednisolone has so many complications, okay? So we will try to consider keeping the dose as optimal as possible. And if the patient requires higher amounts of oral prednisolone, in that case, before considering increasing the dose, we can consider some other newer monoclonal antibody. One of the most common monoclonal antibody that is used in case of asthma management is omalizumab. Omalizumab, okay? All right. All right, so now in case of the step 1 and step 2, the newest and the latest guideline is saying that instead of starting SABA in step 1, you should consider inhaled corticosteroid, okay? So now this is actually the latest guideline that is saying, so from the step 1, inhale corticosteroid in the lowest dose possible. If the patient is still symptomatic, then increase the dose to 400 mcg and add a SABA, okay? This is the only change. Apart from that, all the other changes like in the step 3, 4, 5, this is actually normal. Just yes, inhale corticosteroid actually nowadays has been suggested that you should start it from step 1, okay? Here, previously they would focus on the reliever, more focus on the reliever. But nowadays, there are hypotheses and proven studies that are actually showing that you should focus on the preventer first. Inhale corticosteroid will actually work as a preventer here, okay? Now, there are some general informations regarding the leukotriene receptor antagonist. First of all, this is started from step 3 management, okay, for asthma, started from step 3. Especially if a patient is still symptomatic after trial of SABA, LABA, and inhaled corticosteroid, okay. Another information is this is particularly useful in aspirin-induced asthma, because in aspirin, the mediator is leukotriene, which causes bronchospasm. So if the culprit is basically aspirin-induced asthma, then most benefit will be derived from using the leukotriene receptor antagonist. Okay. Number 2 is it has some side effects as well. And one of the common side effects, which I will discuss in our second class, is it can cause or induce Churg-Strauss syndrome, which is a pulmonary renal syndrome or a type of vasculitis, small vessel vasculitis. So another name for Churg-Strauss syndrome is the eosinophilic granulomatosis with polyangiitis, EGPA. It can cause worsening of the symptoms of Churg-Strauss, okay? All right, next up is acute severe asthma. Severe asthma. So according to the 2010 NICE guideline, the acute severe asthma is classified generally into 3 groups, okay? Number 1 is moderate asthma, which is not our concern. Number 2 is severe attacks of asthma. And this is important, and very, very important is life-threatening asthma. Understanding the feature of each of these different varieties of severe asthma is particularly important, okay? All right, so in case of the moderate severe asthma, the peak expiratory flow rate is more than 50%, and the patient can complete sentences. Respiratory rate is less than 25 breaths per minute, and heart rate or pulse is less than 110 beats per minute. Severe asthma will be the opposite. So the peak expiratory flow rate is within 33 to 50%. Patient cannot complete sentences. Respiratory rate is more than 25 breaths per minute, and pulse is more than 110 beats per minute. Life-threatening, on the other hand, the peak expiratory flow rate is less than 33%. Oxygen saturation on room air is less than 92%. There is evidence of silent chest, cyanosis, or bradycardia. Patient is in coma, exhaustion, flail chest, okay? So these are or confusion. These are all the characteristic hallmark of life-threatening severe asthma. And here the only management is refer the patient to intensive thoracic unit, ITU, and consider for mechanical ventilation. All right. Next up is management for acute severe asthma. Apart from considering admission of the patient, high flow oxygen, nebulization with a bronchodilator, giving the patient with injectable steroid, you should consider IV Maxilf, okay? So in case of the brittle variety or the acute severe asthma, IV Maxilf is given like 1.2 to 2 gram IV infusion over 20 minutes. And if the patient is still showing no improvement, then you can go for injectable salbutamol. And if the patient is still showing no improvement, then consider transfer to intensive thoracic unit and mechanical ventilation. In a lot of books, this is just a simplified chart. In a lot of books, they have mentioned about using IV aminophylins, but I will say like this is not really recommended by the NICE guideline in the recent times, so no need to give it as a correct option. Just remember this algorithm, despite the maximum guideline-directed medical treatment recommended for asthma, if the patient is still not symptomatic, then you can consider IV Maxilf, still refractory IV salbutamol, still refractory ITU transfer, okay? All right. So, so far, any questions for asthma? Okay. All right. So our next topic is COPD or COAD, chronic obstructive pulmonary disease or chronic obstructive airway disease. Again, this is actually a 5-star topic for part 1 examination particularly. So COPD patient, diagnostic criteria, more than 35 years, okay? COPD will almost never virtually happen in any patient. Younger than that, there is except one rule. Okay, can anybody tell me? Alpha-1 antitrypsin deficiency, which is a genetic condition. All right. So more than 35 years of age, significant history of smoking, at least more than 20 pack per year. Okay, and number 3 is even with minimal, in this clinical scenario, like an elderly patient or middle age, like 40 to 45 years of age, he is a current smoker or an ex-smoker, having minimal sign symptoms such as even cough, you should consider the diagnosis of COPD. So a symptomatic patient like cough, shortness of breath, progressive breathing difficulty, all this thing, or maybe tiredness, fatigue. So apart from that, there are some further diagnostic criteria like FEV1 FVC ratio will be showing less than 0.7%. Okay, or 70% less than 70%. All right. And chest x-ray will be showing features of hyperinflation. At the same time, the patient will be having, I think I've already mentioned smoker. Okay, in the complete blood count, if there is any evidence of polycythemia. So apart from these symptoms, you should take into consideration of these particular features, and then you can consider a diagnosis of chronic obstructive pulmonary disease. Severity of pulmonary disease, COPD. Which one is used? According to the gold stage criteria, FEV1 is used as prognostic marker, not as a diagnostic tool. So FEV1 ratio and the staging will be basically, first of all, mild, moderate, severe, very severe. Mild is when the FEV1 is more than 80% of the predicted value. Very severe is less than 30%. Severe is 30 to 50%, and moderate is 50 to 80%. And you can expect a lot of question from the moderate section, moderate COPD, okay? All right. Apart from the FEV1, there are some other criteria that can make you, considering the prognostic value of a COPD patient. This is termed as Bode index. So B is basically BMI. So prognosis is poor if the BMI is more than 30 kg per meter square. O is for obstruction, which is measured by the FEV1, and I have described about this according to the gold stage criteria. D is for distance walked in meter. And E is for, sorry, I'm just going to write it here, exercise intolerance. So this is actually the comprehensive tool to assess the prognosis of a COPD patient, the Bode index. All right, now management of COPD. First up, there is some general management, and there is some pharmacological management, and there is some surgical management as well. So for the general management, buildup of the body nutrition, smoking cessation, most important part, okay? Smoking cessation, and chest rehabilitation or chest physiotherapy. At the same time, vaccination. So yearly flu vaccination and 5-yearly pneumococcal vaccination. These are particularly important. Among the pharmacological management, important one is you can, as a first line, you can consider either SABA or SAMA, which is short-acting muscarinic antagonist, okay? So these are the first line. From there, if the patient is having even one episode of exacerbation or still showing signs symptoms, then you can divide the treatment considering the FEV1. So if the FEV1 is more than 50%, basically meaning that the patient is having stage 1 or stage 2, in that case, you can consider either LABA, adding the LABA, or LAMA, either one of them, okay? However, if this is if the FEV1 is less than 50%, or the patient is having stage 3 or 4, okay? So in that case, you can consider LABA with inhaled corticosteroid or LAMA with inhaled corticosteroid, okay? And if the patient is still showing signs, symptoms, in that case, you can go for the triple therapy, which is basically LABA plus LAMA plus ICS. Actually, in our country, the moment a person is diagnosed with COPD, I think this is the scheme that our physicians go for, like the triple therapy from the very beginning. And in case of asthma management, I think step 3 is maintained in our country, like a reliever, inhaled corticosteroid, and leukotriene receptor antagonist is given all together. This is actually quite sad practice. I think you should not practice the use of using big gun to just kill a mosquito, okay? So if the patient is not showing any signs, symptoms, you have to respect the patient's own body repairing mechanism. Because if from a very beginning you start a patient with inhaled corticosteroid, and then what you make the person's body, like more dependent on the steroid. So in the long run, the patient's symptoms will not be controlled without the steroid. You see the problem here? So that's why same thing goes for our country antibiotic management. Like any patient with any complaint of fever, the first line of management will be injectable ceftriaxone. And this is so wrong in so many different levels, because that is the sole responsibility for us not to go for this kind of like overuse of antibiotic. Okay. All right, so within the pharmacological management, there is another important discussion is that despite the maximal treatment, like combination of LABA, LAMA, and inhaled corticosteroid, and maybe prophylactic antibiotic, the patient is still showing signs, symptoms. In that case, you can consider for long-term oxygen treatment, or the LTOT therapy. So there are 3 things that will actually improve mortality regarding COPD patients. One is stop smoking at any point, okay? Stop smoking. This will improve the survivability. Number 2 is LTOT therapy. Number 3 is lung volume reduction surgeries, okay? So these are the 3 things that will improve the mortality associated with COPD patients. So there are several indications for the long-term oxygen therapy. According to the 2010 NICE recommendation, it has been postulated that a patient should be on LTOT for a minimum of 15 hours. And nowadays, it is the window period is actually increased. So now they're saying that a minimum of 18 hours of LTOT therapy should be given. Okay. Number 2 important information is, before considering for LTOT patient, you should assess the patient's FEV1. So if the patient's FEV1 is less than 30%, which indicates the patient is having severe COPD, very severe COPD, okay, in that case, no other thing to consider, you can go for the LTOT. However, if the patient is within a borderline range, like the patient is having 30 to 50% of FEV1, which is meaning patient is having severe COPD, right? So in that case, you should also take into consideration of development of cyanosis in the physical examination, whether there is any polycythemia, whether there is any leg edema, if there is any evidence of raised JVP, okay? And if the patient is oxygen saturation is less than 92% on room air, in that case, you can go for the LTOT treatment for this particular group. Okay, next up is, we should go for serial ABG. Serial ABG done in 2 separate occasions, 3 weeks apart, okay, to consider for the LTOT treatment. So in 2 of this occasion, if the ABG is showing that the partial pressure of oxygen is less than 7.3 kilopascal, then you can go for LTOT treatment. And if the patient's partial pressure of oxygen is within 7.3 to 8 kilopascal, in that case, you can also consider LTOT if the patient is having any one of the following. So number one is secondary polycythemia. Number two is nocturnal hypoxemia. Number three is pulmonary hypertension. Number four is cor pulmonale or pulmonary edema. So if any of these features are present, then even the partial pressure of oxygen is within normal range, you can still go for the long-term oxygen therapy, because in the long run, these kind of patients will benefit from taking this kind of therapy. Okay, so any information regarding long-term oxygen therapy is very, 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 very important, okay? Do take it into under consideration. You can expect one question at least from the part one examination. Okay. I will just take like 5 minutes of break because there is azan going on. It's prayer time. So I'll be back after 5 minutes. So far we have discussed about the management, like the general management for COPD and the pharmacological management for COPD, and long-term oxygen treatment for the management of COPD. And now, what if the patient is like having frequent exacerbation, and patient needs to be, patient symptom is not under well control, and the patient was on the long-term oxygen therapy, still patient's condition has deteriorated further. In that case, there is options like non-invasive ventilation or NIV, okay? So non-invasive ventilation, there are usually two forms. One is the BiPAP, which is the bilevel positive airway pressure, and then the CPAP, which is the continuous positive airway pressure. So BiPAP is actually considered to be better fitting for COPD patients or any obstructive airway disease management. So BiPAP, in case of a BiPAP, what happens is that the expired compared to the expiratory pressure, inspiratory pressure is more. Okay, inspiratory pressure is more than the expiratory pressure. In case of the CPAP, the pressure is maintained equally between inspiratory and expiratory phase. And there are some characteristic criteria for the BiPAP management for COPD patients. Before considering that, apart from COPD patients with type 2 respiratory failure, there are several other indications, okay? Number one is type 2 respiratory failure from any neuromuscular junction disease, or maybe from, like any skeletal deformity. So type 2 respiratory failure is actually one of the important indication. Number three is when you're weaning off a certain patient from mechanical intubation. In that case, you can go for non-invasive ventilation. And number four is cardiogenic pulmonary edema not responding to CPAP. In that case, you can also go for the BiPAP or non-invasive ventilation. Now, the characteristic criteria for maintaining a non-invasive ventilation in case of a COPD patient management, first of all, the expiratory positive airway pressure should be within 4 to 5 centimeter of water. Number two is inspiratory positive airway pressure should be, according to NICE guideline, they say that 10 centimeter of water, but according to the British Thoracic Society, they're saying 12 to 15 centimeter of water. Oxygen level should be 88 to 92%, okay, because we do not want hypercapnia to take place. And number three is ABG should be repeated every 1 or 2 hourly. FiO2 or the fractionated oxygen should not be more than 40%, okay? And these are literally the information you have to cram because there is no other way around. And I think there's a few other criteria. Let me check, yes. So backup rate. It's a machine where these type of criteria can be set by hand. It's not really rocket science, so no worries about that. So backup respiratory rate should be within 15 breaths per minute. Patient should not be bradypneic or patient should not be tachypneic. And the backup inspiratory versus expiratory ratio should be 1:3. So every inspiration, there should be 3 expiratory cycles, all right? And these are the information you should consider for BiPAP management in case of a COPD patient. EPAP, 4 to 5 centimeter of water. IPAP, 12 to 15 centimeter of water. Oxygen saturation should be 88 to 92%. ABG should be done every 1 or 2 hourly. FiO2 should not be more than 40%. And backup respiratory rate is 15 breaths per minute. Backup inspiration and expiration ratio should be 1:3. So in the true-false statement, what they can do is they can flip the ratio. Like they can give you inspiratory-expiratory ratio 3:1. So that will be false, okay? So instead of the IPAP, they can exchange it for the EPAP and give you the same estimation of IPAP, okay? So this is another way of everybody will be able to understand this level for COPD patients. ABG should be done 1 to 2 hourly. They will not change probably, but they will change between the EPAP and the IPAP level and the inspiration-expiration ratio cycles. All right, and the surgical approaches, basically lung volume reduction surgery is of particularly great importance. And if there is development of bullous emphysema, then bullectomy can also be considered. And last but not the least, the last remaining resort will be lung transplantation. Okay, so different types of emphysema, I think I'm just going to give like a very rough estimation. So emphysema, I think in COPD, everybody knows that there are 2 varieties. One is chronic bronchitis and one is emphysema. Chronic bronchitis, this patient is having more than 3 months of productive cough in consecutive last 2 years. And emphysema basically means hyperinflated lung field, hyperinflation. This has a poorer prognosis compared to chronic bronchitis. One of the dangerous complication from emphysema is the bulla that forms within the emphysematous changes. It can get ruptured, thereby causing tension pneumothorax. Okay. So there are, depending on the location or the involvement of the respiratory unit, emphysema is basically of 4 types. One is pan-assigner. You don't have to go through the details. Just remember the pan-assigner is particularly involving the lower lobes. Okay. Number 2 is sentry-assigner. This particularly involves the upper lobes. There is a congenital variety known as congenital lung emphysema or CLE. This is more predominantly seen among the young individuals. And number 4 is, let me check, yeah, paraseptal. Paraseptal, this is mainly seen in young, thin individuals, and location is subpleural. They can easily rupture and cause spontaneous pneumothorax, the paraseptal variety. Okay, sentry-assigner is mainly seen among the older patient. All right, that's literally all you need to know. And another important topic that I've mentioned is in the young patient, if a patient is showing features of chronic obstructive pulmonary disease, then I've told you to consider one genetic condition, which is alpha-1 antitrypsin deficiency. So this is an autosomal dominant condition, more seen among the non-smokers. And basically treatment is lung transplantation if the patient is symptomatic. And the genotype is particularly important. So there are different genotypes. I will just write it down: PIMM, PIMZ, PISS, PISZ, PIZZ. So if it's like a gradient, if the patient is having PIMM genotype, patient will be having no sign symptoms. Patient is not even a carrier, not a carrier. MZ means patient is a carrier and no sign symptom or no asymptomatic. From here, from the SS to SZ and ZZ, they might have more chances of showing sign symptoms, and ZZ has the most chances of having all the complications related to COPD. Symptomatic plus complications. All right. So for any confusion for the alpha-1 antitrypsin or the management of asthma COPD so far? I understand that the LTOT indication is particularly very important, and remembering the non-invasive ventilation criteria is something that you have to literally cram. There is no shortcut to it. You can write this information down. It will just take like maybe 5 to 10 minutes for you to remember all this information altogether. Okay, so in case of acute COPD, sometimes there might be some questions like acute exacerbation of COPD patient. So what's the management like? First of all, consider admission because the patient might deteriorate in home management. Number 2, you should consider oxygen, but low flow, low concentration. Why? We have read about this so many times back in our 5th year level, okay? So your oxygen saturation level should be 88 to 92%, not more than that. Initially, it should be given by 28% venturi mask to maintain this oxygen saturation level. And number 2 is, and in some individuals, they can also provide this through nasal prongs as well, depending on the availability. But venturi mask is preferred, of course. Number 3 is give the patient injectable steroid, prophylactic IV antibiotic, broad spectrum IV antibiotic, and bronchodilators. Bronchodilators in the form of nebulization with salbutamol and ipratropium bromide, and maybe even LAMA as well. Okay, so we will observe the patient after giving this type of medication. If the patient is not showing any symptomatic improvement, we can go for non-invasive ventilation. And towards the end, if still the patient is symptomatic and patient becomes unconscious and all this thing, we can consider mechanical intubation. And chances of recovering from mechanical intubation in COPD patient is very slim compared to asthma patient. Because in asthma patient, this is not a chronic progressive condition. So if all on a sudden there is some life-threatening condition and you go for intubating the patient, there is high chances of going back to the normal stage because the lung function is not compromised yet. But in case of COPD, there are progressive chronic changes within the lung, small airway, okay? This is irreversible condition. So after you go for mechanical intubation, the chances of revival is very slim in COPD patient. So sometimes in very critical situation, in particularly COPD patient, mechanical intubation is not even considered as an option because there is no added benefit. All right, so regarding oxygen therapy, another important information is if the patient is having no clinical symptoms of hypoxia, then you should not just go for oxygen in any patient. That will cause more oxygen-induced brain injury, okay? Especially in our country or in lots of other countries, they do practice giving high flow oxygen in critically ill patients like maybe MI, acute coronary syndrome, stroke, obstetric emergencies. These type of condition, they like routinely practice giving high flow oxygen. This is something contraindicated. If the patient is clinically not hypoxic, like the saturation level is more than 92%, the patient is able to maintain his or her saturation level at a normal bare minimum level, no need for going for any further supplemental oxygen, okay? All right, I think I've covered most of the information from asthma and COPD. So before I proceed with the pulmonary embolism and the pneumonia, which is not really that big of a topic, I'm just going to ask you guys some questions, okay? I hope by this time everyone has got the book so far, even the hard copies. Okay, so question number 10, I hope you can see this. Okay, we'll start with Dr. Obijit, you can start. Question number 10. Can you see this? Yeah. Okay. You can think it to yourself. There's no worries. I think everybody can see the screen. So this is a characteristic finding or criteria for life-threatening attack, right? So which of the following feature is the most likely to indicate a life-threatening attack? Which one do you think? Cannot complete sentence will be under the severe asthma, not 30%, yes. because the peak expiratory flow rate, if this is less than 33% of the predicted value, that will be the answer. So option D is the correct answer. All right. Thank you for trying. And among the participants, Dr. Moinul Ibn Mannan, can you unmute yourself?
Hello.
Yes. So can you give me the answer of question number 13? It's a bit lengthy, so I will try to break it to you, and then all you have to do is pick up the right option. So you're called to review a 19-year-old woman with asthma who presented to the emergency department approximately 30 minutes ago with acute shortness of breath. She is well known to staff and has 2 previous episodes of ITU admission for her asthma. At initial presentation in the ED, she was tachycardic at 126 beats per minute, normotensive with a respiratory rate of 30. Saturation is 94% on 4 liter per minute oxygen via face mask. On clerking, so that is indicative of a severe asthma, okay, not a life-threatening asthma yet. On clerking, doctor noted widespread polyphonic wheeze on auscultation of the chest. Following bloods were obtained at the time of presentation. So our important focus should be given here, not really anything at all. Let's move on. Chest X-ray showed no acute abnormality. Peak flow was 40% of the predicted value. Initial ABG on 4 liter per minute oxygen is pH is 7.45, which is normal. PCO2 is 3.6. Partial pressure of oxygen is still normal. Okay, let's go on to the next part. So the F2 started treatment for acute severe asthma. She has been given back-to-back salbutamol and ipratropium nebulizer, IV Coxon and IV Maxalt. So maximum amount of treatment has already been given to this patient. On your arrival, the patient is in the resuscitation suite. The F2 informs you that they have attempted to perform a repeat ABG, but were unable to obtain a sample as the patient is confused and combative. As a result, they also cannot provide a meaningful repeat peak flow reading. Patient's vital signs are largely unchanged since initial presentation. She's maintaining saturation of 95% on 4 liter per minute by the face mask with a respiratory rate 27, heart rate 130, and she is normotensive. ECG is difficult to interpret but does show sinus tachy. On auscultation of the chest, you hear a widespread polyphonic wheeze. Given the limited information you have, what is the most appropriate immediate action? Obtain a repeat ABG, IV salbutamol, aminophylline infusion, referral to the intensive care, nebulized magnesium sulfate. So this was a quite large stem, and actually some questions can be in the form like this. In the real-time exam scenarios, there might be 2 or 3 questions having this kind of very big stem. But there is one very important clue that has been provided in the stem, okay? So I hope you got that. And now can you try to give me the answer, Dr. Moinul?
I think it's a C.
C is aminophylline infusion. Do you think this is the correct answer?
I think, but I'm not sure.
Okay, no problem. So actually, when I was talking about the management of life-threatening or brittle asthma, I have already mentioned, like if the patient is on IV Maxalt, and the next line of treatment should be IV salbutamol. Oh. There is usually no role of aminophylline, okay? And if the patient is still being not responsive, then you can consider transferring the patient to the ITU and considering for mechanical intubation. Okay. Now, here's the catch, okay? I know you're probably thinking, so this might be the option B. But the answer is actually option D, referral to the intensive care. The reason is, even though initially the patient is showing severe asthma, not a life-threatening asthma, however, in the second portion, you get only one word, and that is confusion, okay? So which is a marker, single marker for life-threatening asthma. So despite the patient's all the other presentation, as the patient still after taking oxygen and all the treatment for acute severe asthma, the patient has become confused. So that is the most important portion that will make you think like, okay, no, the condition is actually accelerating. So now our next appropriate immediate action should be referring the patient to the ITU. Okay, Dr. Moinul, have you understood?
Yeah, okay, thank you.
Okay, no worries. All right, so next up is question 19. So, all right, Dr. Kobir, this one's for you. So the patient is, this is a young female, known history of asthma. She's having salbutamol, which is the SABA, and ICS 400 mcg and LABA therapy. Okay. So last week she found out that she was pregnant and she stopped this medication herself because she's concerned about the potential harm to the pregnancy. Now, what's the most appropriate action? Reduce the dose of steroid and continue salmeterol at the same dose. Stop steroid and salmeterol inhaler. Refer to respiratory physician. Reduce the inhaled corticosteroid dose to 200 and stop salmeterol. Restart the beclomethasone at the same dose and stop salmeterol. Number 5 is reassure and restart beclomethasone and salmeterol inhaler. So which one is the option? B. You're thinking like stopping both of this medication and referring to the respiratory physician is the appropriate action. Okay, unfortunately the answer is E, because the patient is having inhaled beclomethasone and inhaled salmeterol. As long as the patient is taking these through the inhaler, there is no potential side effect that can arise or cause harm to the baby. Rather, her asthma can get flared up during her pregnancy. Okay, so that's why control of her asthma is the first priority. So the patient is already on various inhaled therapy, so no need to consider for stopping any medication. Yes, in like beclomethasone more than 800 mcg, that can sometimes be having like systemic absorption, and they do have sometimes a very minimal chances of causing some complication that might arise with systemic steroid. But the patient is having a very minimal amount of beclomethasone, so no reason to stop any of this medication. Okay, so the answer is option E. All right, let's see, Dr. Protasha, if you can you hear can you hear me? Can you unmute yourself?
Yes, I can hear you.
Okay, so question number, let's see, 23. Why is the question 25 is missing here? Okay, no worries. Question number 30, okay? Can you see the question?
Yes, ma'am.
I'm gonna scroll, is that okay?
PIMZ should be the answer.
Okay.
Clinically significant symptoms does not.
Yes, so which one is the most likely genotype? What's your option?
PIMZ.
So option A?
Yes.
Yes, very good. This is the option A, because the patient is not symptomatic. There is positive family history, no symptom, but she's a carrier of this condition. So the most likely genotype is PIMZ. Very good. Okay, so next question is, let's see, Dr. Umaid Yusuf, can you unmute yourself?
Yes, ma'am.
Okay, so question number 31, this one's for you.
Yes. A, PIZZ.
Yes, very good. Because why? The patient is having symptoms. All right.
Yes,
So
ma'am.
this must be PIZZ. Okay, very good. All right. Next question is, let's see. Dr. Himali Amin, can you unmute yourself?
Yes.
Okay, so question number, question number 40. Do you want me to scroll?
Yes, please. Option number C.
Option number C, okay. So this is saying that LABA or LAMA plus ICS in a combination inhaler. Okay, unfortunately, this was actually option number E, because the clue is patient is having COPD, but the FEV1 is more than 50%, okay? So that means the patient is either in stage 1 or 2. All right, so in that case, if the FEV1 is more than 50%, in that case, after trying the first line, which is the SABA or the SAMA, you can consider either adding the LABA or the LAMA, not both of them, okay? And there is no role of inhaled corticosteroid as of yet, okay? So the option is actually option number E, which is indicating either LABA or LAMA, all right? No problem. Okay, question number, thank you for trying. Let's see, Dr. Mariam Bhatt, can you unmute yourself?
Yes.
Okay, so question number 45 is for you.
I guess B.
Your option is B?
I guess B.
B, okay, yes, you're right, very good. The option is showing that hemoglobin 18.4 is indicative of polycythemia. So that will be an assessment factor for consideration of LTOT therapy. Here, FEV1 should have been less than 30% of the predicted value, okay? In that case, we could have gone for the LTOT. And body mass index is not a characteristic for consideration of LTOT. Oxygen saturation should have been less than 92% on room air. And FEV1 FVC ratio is not a characteristic for assessment. Okay, all right, very good. Let's see, I still have some questions. All right, question number 49. So 49. I think it's a bit mixed and match over here. Everyone had one chance. Okay, so I'll start from the beginning. So Dr. Obhijit, question number 49. Okay, have you seen that? Okay. Okay, very good. Yes, this is the option C. Why do you think that? Yes, pH, if the pH is less than 7.35, this is one of the indications of starting non-invasive ventilation. And the patient has already received 2 liters low flow oxygen at the same time. No point of going for another round of this. All right, very good. Okay, I think I just have another question. Who was in the second trial? Dr. Kobir, you were? Okay, so question number 53. Yeah. D. So what does the clinical stem tell you? That the patient is suffering from stroke. The patient is having stroke and oxygen saturation is normal. So in that case, no oxygen therapy, okay? So the option is option C. All right. So next one I think was Dr. Moinul Ibn Mannan. Could you please unmute yourself?
Yes, hello.
Yes, okay. So question number, let's see, 50. Actually, do you have the book to yourself? Because I wanted to give you question number 54. Unfortunately, this is not in here. Do you have the question book to yourself?
No, it's in online.
Okay, all right. So I think we will start the round again after I'm done with the pulmonary embolism discussion. Okay, so the next person will be, I'll start with you. All right, thank you. Okay, now our topic of discussion is pulmonary embolism. Pulmonary embolism, first of all, this is a medical emergency. It's a life-threatening condition. And in pulmonary embolism, what happens, there is some blood clot within the pulmonary vasculature, all right? And common feature is shortness of breath. Number 2 is pleuritic chest pain, cough, sometimes even with hemoptysis it can happen, cough or hemoptysis, and sometimes even low-grade fever can take place in a patient with pulmonary embolism. So what are the risk factors for developing pulmonary embolism? Risk factors. Number 1, long haul flight, okay, long flight. Number 2, immobilization. Number 3, dehydration. Any underlying malignancy. Number 4, prothrombotic condition, like female taking oral contraceptive pill, women with antiphospholipid syndrome, women or men having antiphospholipid syndrome, protein C, protein S deficiency, or antithrombin 3 deficiency, or factor V Leiden mutation. So all these conditions are prothrombotic condition. These are basically some of the risk factors that are associated with pulmonary embolism or any past history of or recent history of deep vein thrombosis that can also cause pulmonary embolism at the same time. Okay. So initially, after you are suspecting that the patient is having pulmonary embolism, first initial investigation should be chest X-ray. For any lung problem, you should go for chest X-ray PA view. However, in case of a pulmonary embolism, chest X-ray most of the time is normal. Okay. So next up, in a lot of centers, they go for D-dimer. However, D-dimer is a non-specific marker. It's sensitive, but it's non-specific. Especially even in pregnant women, D-dimer is normally raised. So if you're suspecting pulmonary embolism in pregnant women, will D-dimer help you in diagnosing that? No. So D-dimer is not useful at all. Okay, number 3, this is just an adjunct, like in order to make you consider this might be a case of D-dimer, but not for diagnostic purpose. Okay. Number 3 is very, very important line of investigation is CTPA, okay, or CT pulmonary angiogram versus ventilation perfusion scan or the VQ scan. So CTPA can be done within few minutes, like it's very speedy procedure. Ventilation perfusion scan is comparatively slower. This is widely available. VQ scan is, in some centers, VQ scans can be available, CTPA is, compared to VQ scan, even less readily available. This is more sensitive and specific. After doing the chest X-ray, if you have strong suspicion of pulmonary embolism, if the next modality of investigation should be CTPA, okay? CTPA, CTPA, CTPA. Never VQ scan in the option. If there is no mention of CTPA, only then you can go for the VQ scanning, all right? In pregnancy, there are some debates, like CTPA, it has like some radiation exposure. So in that case, sometimes VQ scanning can be preferred in pregnant women only. However, the gold standard is pulmonary angiography, which is a invasive procedure. This is gold standard. However, this is invasive, so there are more complications related to pulmonary angiogram, thus making CTPA the main investigation modality. All right. So sometimes CTPA has some difficulty in picking up the segmental, subsegmental arteries, like they're not able to reach or properly capture the very peripheral artery embolism involvement, okay? So subsegmental artery involvement can be missed in CTPA. All right, so for pulmonary embolism, treatment of pulmonary embolism, this is particularly important. So initially, low molecular weight heparin is given rather than unfractionated heparin. So low molecular weight heparin like enoxaparin or Clexane in our country, Clexane is widely available. So this is given in the very initial period, unless there is massive pulmonary embolism. So what does a massive pulmonary embolism mean? When there is hemodynamic compromise. Hemodynamic compromise. So that means blood pressure, if this is less than 90/60, and if the heart rate is with more than 100 beats per minute, or maybe even less than 40 beats per minute, then you can consider there is some form of hemodynamic instability. In case of a massive pulmonary embolism, main modality of treatment is thrombolysis. Either chemical thrombolysis, like with the help of thrombolytic agents, for example, altiplase, tenecteplase, or tissue plasminogen activator, or even mechanical thrombectomy can be considered, okay? All right, so there is too many debates regarding the duration of anticoagulation. In NICE guideline, recently they're saying that instead of going for low molecular weight heparin in the initial period, they're considering NOACs in the very beginning, okay? So for part 1 examination, I would advise you to focus on the backdated guideline just a bit, because this is theoretical knowledge, okay? Number 2 is duration of anticoagulation. First of all, you should consider whether this is a provoked event or unprovoked. Whether there is how many episodes, recurrent or single episode. Whether this is arterial versus venous. So usually if there is arterial involvement, this is unprovoked event and there is recurrent thromboembolism. So it's either for a longer duration like 6 months, and in case of arterial involvement, there is lifelong anticoagulation. But we are talking about pulmonary embolism itself, so we will keep this a bit aside, okay? We will think of only provoked versus unprovoked and recurrent versus single. If this is a provoked event and only single time it has happened, and there is no immediate risk factor, in that case, we can go for the anticoagulation for 3 months. However, 6 months is ideally given nowadays, okay? And if there is no risk factor in the long term, then no chance, no reason to go for lifelong anticoagulation, because it causes some complications like bleeding. Previously in the NICE guideline, I think the CAF DBT had only 3 weeks of anticoagulation, but now it has been changed and they're considering to just go for 3 months now, 3 months of anticoagulation. Actually, when I will give you the scenarios, it will become a bit more evident, like how to take the decision, okay? All right, next up, we will discuss about pneumonia, and this is our last topic, and then towards the end, we will go through the question answer session again. So for pneumonia, first of all, the culprit organism. For example, most common cause of community acquired pneumonia is Streptococcus pneumoniae. All right. Streptococcus pneumoniae can cause reactivation of herpes simplex. So there might be cold sore like herpes labialis. Okay. All right. Number 2 is Klebsiella. Klebsiella can cause pneumonia, particularly in alcoholics. So look for the clue alcoholic in the stem. It usually causes cavitation or lung abscess. And it has a higher mortality rate compared to the other organism, reaching to 30 to 50% of mortality. Okay. Number 3 is, Dr. Kobe, focus on the lecture. You can find it when you go back to your home. Staph aureus. Staph aureus is mainly considered this a case of culprit organism in immunocompromised patients, okay? Like diabetic individuals. Also, another clue will be there might be a preceding flu-like illness and then a full-blown bacterial pneumonia picture. So that is indicative of Staph aureus infection. And it can also cause multiple cavitary and abscess in the lung as well. And it has quite a high mortality, just like Klebsiella. Okay. Now we will discuss about some atypical organism. Among the atypical organism, for part 1 and part 2, two important organism is very important. One is Mycoplasma, and the other one is Legionella pneumophilia or Legionnaire's disease. Legionnaire's disease. Okay. So, what's the characteristic of an atypical pneumonia? First of all, they are not present in the typical culture medium. Okay. So when you go for a throat swab or if you're going for the blood culture, they will not show up. This is the characteristic feature of atypical pneumonia. So the Mycoplasma pneumoniae, what will it do? It usually affects the young individuals. It takes place in where there is close proximity to people, like in the boarding school or maybe in the dormitories, okay? Boarding school, dorms. Usually in the UK, every 4 years, there is an endemic of the Mycoplasma pneumoniae. Mycoplasma pneumoniae also causes skin rashes like erythema multiforme. So skin rash, apart from pneumonia, it's another important way of detecting Mycoplasma pneumonia. Another one is it can cause cold autoantibody induced autoimmune hemolysis, thereby leading to anemia and thrombocytopenia. And apart from that, usually compared to the regular pneumonia, in the atypical pneumonia, the fever is not that high. So it usually causes low-grade fever, dry cough, like shortness of breathing, and prodromal symptoms are more evident in the Mycoplasma or the atypical pneumonia. And it can also involve the other organs, like in the heart, it can cause pericarditis, myocarditis. In the abdomen, it can cause hepatitis or pancreatitis. It can also cause hematuria by causing acute glomerulonephritis, okay? Hematuria, another important finding for Mycoplasma pneumonia. So a patient with a low-grade fever, prodromal-like illness, skin rashes, maybe he or she is from boarding school and now presented with hematuria, you should consider the diagnosis of Mycoplasma pneumonia, all right? Chest X-ray usually showing bilateral consolidation. In typical pneumonia, we know that this is usually fixed to a particular lobe or a particular segment of the lung, and the finding is usually unilateral unless the person is severely immunocompromised. But in case of the atypical pneumonia, they usually have bilateral presentation, bilateral consolidation. Okay, treatment is erythromycin or clarithromycin if the patient is intolerant or contraindicated to erythromycin. An alternative medication is doxycycline. But erythromycin is the first line. For Legionnaire's disease, this is caused by a gram-negative bacilli, which is an atypical bacteria, intracellular bacteria, and clue can be there might be a history of foreign travel. This type of bacteria is predominantly found in the water tanks. So the clues might be air conditioning system or cooling devices. Okay, so that's another clue. And just like Mycoplasma pneumonia, Legionnaire disease can also present like low-grade fever, cough, dry cough, and some breathing difficulty. And there is also bilateral consolidation in case of Legionnaire's disease as well. Here, it can also cause hematuria, or it has renal involvement, and it can cause lymphopenia. In the blood count, it can cause lymphopenia without marked leukocytosis. So the WBC total count might be normal and the leukocyte count will be reduced. Okay, and if you go for the electrolyte, serum urea electrolyte, you'll see there is evidence of hyponatremia. Hyponatremia syndrome of inappropriate antidiuretic hormone secretion can take place in any of the atypical pneumonia, which is predominantly more seen in Legionnaire's disease. Okay, all right. And here investigation, confirmatory investigation is urinary antigen. All right, and treatment is the same like Mycoplasma, that is erythromycin. If intolerant, you can go for doxycycline, but erythromycin is the first line. All right, next up is for pneumonia, there is prognostic marker is CARP65. The C stands for confusion. So in the abbreviated mental state examination, if the score is less than 8, then this is considered to be significant. U stands for serum urea level more than 7 millimole per liter. R stands for respiratory rate. So what's the cutoff point? More than 30 breaths per minute. I'm not sure, I'm asking you. Okay, and B stands for blood pressure. So the systolic is less than 90 over diastolic less than 60 millimeter mercury. Age is more than 65 years of age. So these are 4 prognostic features of pneumonia. And if the score is 3 equal or more than 3, then hospital admission is mandatory. Hospital admission. All right. Apart from these, other core prognostic feature would be presence of comorbidities, and if initially the patient is having hypoxia, so the partial pressure of oxygen is less than 7.3 kilopascal. That is also indicative of poor prognosis. So what's the treatment for pneumonia? So if the score is within 0 to 2, in that case, we can discharge the patient. Home treatment is sufficient enough and oral treatment is given to the patient. Initially, oral amoxicillin. Amoxicillin. Okay. And yeah, no other medication is required. If the patient is sensitive or like has penicillin allergy, you can go for like erythromycin or like antibiotics like that. But amoxicillin is the first line. And if the patient is having severe community acquired pneumonia, in that case, you should consider IV antibiotic. Okay, like combination form, either IV coamoxiclav plus clarithromycin. In our country, clarithromycin is available in binoclear, right? Binoclear tablet. Or this is a combination, or IV cefotaxime plus clarithrol. So a macrolide antibiotic is given in combination with an injectable broad spectrum antibiotic. Okay, that's basically the gist of the treatment protocol. Okay, now a very important and frequently coming topic for part 1 and part 2 written examination is pneumocystis jirovecii or pneumocystis carinii pneumonia, also known as PCP. So first of all, this is an atypical or opportunistic infection. There is a debate whether pneumocystis carinii, whether this is a fungus or protozoa. For our discussion purpose, we will think of it as a eukaryote or the protozoa, okay, protozoal infection. This is seen in HIV positive individuals mainly. However, it can take place in any of the immunocompromised patients as well, because this is an opportunistic infection. And this is seen more likely in HIV patients when the CD4 cell count is less than 200 cells per cubic millimeter, okay? And the CD4 count goes down. Apart from the HIV patient, commonly in our country, even in our country, we go for PCP prophylaxis in patients with nephrotic syndrome, because there is huge range of protein loss, thereby causing the patient more prone to developing this opportunistic infection. Okay. So how can you diagnose a patient with PCP? Before that, clinical features of PCP will be low-grade fever, dry cough, shortness of breath, kind of like COVID, okay? Shortness of breath. And characteristic finding is there will be desaturation on exercise. So if you check the pulse oximetry of these PCP infected individuals, you will see that the patient was having maybe near to normal oxygen saturation when the patient was resting. However, when the patient started to walk or started doing some activity, the oxygen saturation count will be going down low, very similar to COVID infection. All right. So in the chest x-ray, it will cause bilateral pulmonary infiltrate, and sometimes it can also be normal as well. For diagnostic purpose, you should go for a bronchoscopy guided bronchoalveolar lavage and consider silver staining to detect this organism, PCP organism, okay? Now the treatment is basically cotrimoxazole, okay, or IV pentamidine. However, if the patient is hypoxic, meaning that the partial pressure of oxygen is less than 9.3 kilopascal, in that case, systemic steroid or prednisolone is given, because it improves the mortality and also reduces death rate by 1/3, okay? Prednisolone is quite important in hypoxic patients. All right, so far, any question from pulmonary embolism or pneumonia? Okay, I hope I tried to keep the discussion topic a bit short today, because I don't want you guys to get carried away with the respiratory physiology and the asthma and the COPD management. In the next class, I will discuss about the lung cancer, pneumothorax management, and different types of vasculitis, which is so very important for part 1 and part 2 written examination, okay? Not only that, I think in PACES examination, vasculitis is a very important hot topic. Okay, now the question answer session, okay? All right, so Dr. Moirulibde Manan, yes, you've already unmuted yourself. So question number 67, this one's for you. Dr. Manan, can you hear me?
Yes, yes.
Okay, yes, all right. Are you through?
Hello.
Yes, so what's your option, correct option?
I think it's D.
D, okay, oral erythromycin plus discharge.
Yes.
Okay, so why you're thinking that this is a case of oral erythromycin? Is there any mention of penicillin allergy here?
Uh, mm,
No,
I
right?
think I think it's atypical, but I'm not sure.
Okay,
That's why I chose erythromycin.
okay. Actually, this is the stem is not saying anything regarding atypical pneumonia, okay? And the patient is just having a very normal, like here you can see, temperature is raised, so high body temperature. This is not a normal or low-grade fever, okay? Blood pressure normal, respiratory rate is normal, pulse is within normal, so carb score is 0.
0, yes.
Auscultation of the chest reveals bronchial breathing in the left base, unilateral involvement, okay? So this is not atypical pneumonia scenario. So the most suitable management would be oral
Yes.
medication with discharge. And the ideal one is amoxicillin because there is
Amoxicillin.
no mention of penicillin allergy here, okay?
Okay.
All right, no problem, you'll get the next one. All right, so I think Dr. Who was next? Dr. Pratasha, yes. So could you unmute yourself, and question number 72 is for you.
Yes, ma'am. Yes, ma'am.
So Dr. Pratasha, are you through?
Yes, ma'am.
Okay, so which one is your option, correct option?
Ma'am, can you just go back to the question once on the scenario?
Sure.
48 hours of IV.
You want to see the options now?
Yes, ma'am. Oxygen therapy can be commenced if the patient is having insurance.
So you're thinking option E?
Yes, ma'am.
So let's go back to the question stem here. You're bleed by the nurse on the respiratory ward to come and see a 79-year-old woman. So we are already seeing that this is one score for the carb 65 score, okay? Who is currently being treated for carb 3 community acquired pneumonia. So the score is already bad. Patient is already admitted with IV, coamoxiclav, and clarithromycin. Nursing staff are concerned that despite 48 hours of IV therapy, the patient spiked a temperature. So the patient's symptom is not controlled yet. On examination, you note a dull percussion note at the right base with reduced breath sound. So urgent chest X-ray reveals a new right-sided pleural effusion. So if you're getting parapneumonic effusion, your next line of treatment, also therapeutic modality, should be chest drain, because the parapneumonic effusion will act as an infectious nidus, okay? And no matter how many antibiotics you change or increase the dose of the coexisting antibiotic, it will not cause clinical improvement because your effusion is not being drained out yet, okay? So that's why the correct option will be refer the patient for urgent insertion of USG guided chest drain. Did you understand that, Dr. Prabhasha?
Yes, ma'am.
Okay, thank you for trying. Next up is, although I haven't really discussed in my discussion today, I would just like to go to 74 and I will discuss this in this question. So a 61-year-old smoker presents with a 3-week history of worsening breathlessness. A chest X-ray shows a large left-sided pleural effusion. He has a small amount of the effusion aspirated and sent off for examination. Which of the following laboratory results would point to this effusion being an exudative rather than a transudative effusion? So this is actually a question regarding Light's criteria. Sorry. So the Light's criteria is whenever you're having the protein amount is more than 25 mg per dl in case of a pleural fluid aspiration, but this is less than 35, okay? So when this is more than 35, we are sure that this is a case of exudative pleural effusion. But when the range is between 25 to 35, that's when we are having doubts whether this is exudative or transudative. In that case, Light's criteria is applied. So Light's criteria is based on 3 criteria. One is pleural fluid protein versus serum protein. I will just write pleural protein like this and serum protein like this, okay? So serum protein more than 0.5. If the pleural LDH and the serum LDH ratio is more than 0.6, if the pleural LDH is more than 2/3 of the upper limit of serum LDH, that's when the pleural fluid is considered to be exudative rather than transudative. So here you'll see among all the options, the correct answer is option B, because the LDH, effusion LDH level is greater than 2/3 of the upper limit of the serum LDH. All right. All right, next question will be question number 78. Let's see. Dr. Himali Amin, I think you are next in line. So the question number 78, this one's for you.
I think it's
Yes?
A or
Hold that.
D.
A or D, okay? Unfortunately, in examination, that's what will happen, you will be confused in between the two options. So you're going in the right track, I will reassure you. So which one do you think? Is it A or D?
I'll go for A.
We'll go for A. Okay, so actually this is like they're asking for the most likely to be diagnostic, okay? So you want to diagnose this case cold agglutinin will only give you further clues, like this might be a Mycoplasma pneumoniae. However, this serology for Mycoplasma will for sure tell you that this is indeed a case of Mycoplasma pneumoniae. So your correct option was option D. Okay, this will help as this will work as an adjunct diagnostic modality, not the confirmatory. All right. Let's see, Dr. Umayyad, Dr. Umayyad was there. I think he's missing. Also, Dr. Another female doctor was there. Okay, so we will go for this question to Dr. Ovijit. Okay, question number 80. This one. So which one is your answer? Legionella. Okay, very good. Because your clue was hyponatremia and foreign travel. Okay. So Dr. Kovir, 81, question number 81. Confirm the probable diagnosis. Which one do you think? What's the diagnosis? Legionnaire's disease. Okay. In that case, which would be your diagnostic clue? No, in the blood culture, the atypical pneumonia will not show up, right? So what will be the answer? Urinary antigen. In the sputum, no, it will not show up again. That's the characteristic of atypical pneumonia. These are most likely intracellular organisms. They will not show up in the typical blood culture or sputum culture, okay? So the answer is urinary antigen level. For the Mycoplasma, it's the serology for the Mycoplasma or the PCR, and for the Legionella, it is urinary antigen. Okay, so I think Dr. Moinul again, you have to take the question number 91. See? Yes, question number 91. Can you see this?
Yeah.
Okay. Do you understand which type of pneumonia this stem is talking about?
PCP?
PCP, yes, very good. Okay. Now carry on. Read about the ABG carefully and then go for the most appropriate treatment.
Yeah, it's a C.
See, very good. Because you're thinking that there is partial pressure of oxygen is less than 9.3 kilopascals.
No,
So there is
9.3, yes.
Yes, prednisolone, very good. Okay. Cotrimoxazole and prednisolone is the right answer.
Thank you.
All right, very good. Next up, all right. I think we have just few questions left from the pulmonary embolism section, and then we are done. $161. Let's go. Yes. All right. So I think this question goes back to Dr. Pratasha again.
Yes.
Let me drop that.
Option A, urgent CTPA.
Okay. This yes, because you want to establish the diagnosis, right? And you're
Yes.
thinking this is, obviously with the like this portion, which is why I do not really like to take questions from this particular segment, because the first of all you have to diagnose it from the stem. A man with a 3-day history of sudden shortness of breath, pleuritic chest pain, no past medical history, observation is showing there is hypotension. So that means this is a case of massive pulmonary embolism. Saturation is reduced, heart rate is tachycardia, temperature is slightly increased. On examination, lung auscultation is normal, ECG is sinus tachy with right heart strain. He has not responded to adequate fluid resuscitation. In that case, after applying for the high flow oxygen, you should be starting the diagnosis first, like urgent CTPA, and then start the thrombolysis as soon as possible after confirming the diagnosis. So very good on thinking on the right track. All right, so Dr. Himali, the question number 162, this one's for you. Okay, Dr. Himali, are you through?
Yes.
Okay.
Low molecular weight heparin.
Okay, very good. Yes, because this is the initial treatment for acute onset of pulmonary embolism. All right, and the patient is not having massive pulmonary embolism, so no need to go for thrombolysis as of yet. You can just go for the low molecular weight heparin right away. All right, very good. So question number 164, I think, goes to, let's see, it's you, right, Dr. Obhijit? So 164, this one's for you. So recommended length of warfarinization for this patient. Unprovoked, exactly, very good. So this is 6 months, all right. Although apparently she has no risk factors, but this is an unprovoked event. So in that case, you should go for 6 months of anticoagulation, all right. Last but not the least, okay. So goes back to Dr. Kovier. All right. I think it might be a little bit difficult. So actually, this is an open question. Anybody can take it.
B, ma'am, is it the answer? Compression duplex Doppler.
Yes, very good. Who gave this answer, doctor?
Pratyasha.
Okay, yeah, okay, Dr. Pratyasha, you're very right. Because in case of pregnant women, D-dimer will not be of any added value. CTPA cannot be considered right away because this has radiation exposure. Venogram is usually for incompetency, like venous insufficiency. In that case, venogram can be considered. Ventilation perfusion scan, again, this is not a case of ventilation perfusion scan also has some radiation exposure. You need to detect DVT first, like doing a compression duplex Doppler will do. And in that case, it will just, with the temporality of the issues, it will also diagnose the pulmonary embolism at the same time. So compression duplex Doppler is the correct answer. Thank you. for taking the question, and I think you have all done great. Keep practicing like this, and hopefully in the next class we will try to be a bit more interactive, and I hope you enjoyed my session. So I'm ending the session. Thank you all.
Thank you.